At 3 years, the two curves overlaps, with no difference in terms of endpoint. If we look at the individual endpoint, we didn't see any difference. And if we add the ischemia-driven revascularization, there's no difference in terms of endpoint. And clearly, the PCI is as a disadvantage compared to CABG, with a 5% more incidence of needed revascularization. But look at the last part of this table. If we look at stent thrombosis or symptomatic graft occlusion, there's no game among PCI and CABG. The PCI with science has less than 1% stent thrombosis. So we're happy. After this presentation at TCT, I was very happy. But the same session, the results of the NABL were presented. The main difference from among the NABL and Excel was the primary endpoint that included repeat revascularization and it included periprocedural myocardial infarction and the stent used. They used 10% cipher and 90% the myomatrix flex. That's the second generation DES. 1,200 patients with unprotected left main randomized to PCI or CABG. They had they're more or less the same inclusion criteria of the Excel. They didn't look at the syntax, but they stated that the patient didn't have to have more than 2 complex lesions together with in addition to left main stenosis. The syntax score was lower than the Excel. But the PCI did not meet the non-inferiority goal with a very high incidence of MACE. If we look at the individual endpoint, there was an increase of total repeat vascularization, non-procedural MI, and very surprising, a higher incidence of stroke. There was a higher incidence of definite stent thrombosis with cipher and biomatrix. That was my face after this presentation at the last year at TCT. As we just saw, the difference is related to the primary endpoint and the use of the type of DES used. The NOBLE has a higher incidence of death, similar incidence of cardiac death. They didn't look at the periprocedural MI that in the post-hoc analysis was higher than in the NOBLE, than in the Excel. They have a higher incidence of stroke, a higher incidence of definite stent thrombosis, and clearly both Excel and NOBLE have a higher incidence of revascularization. It seems that syntax score is not so important as we thought before, and that's another disturbing question. But if we look at the very different, and we try to explain the difference between the two studies, we can say that the science is different compared to cipher and biomatrix. Has a lower strut thickness and has a fluoropolymer that it seems to have a better safety profile in terms of inflammation. And the stenting technique is important. Most of the double stenting technique used in the NOBLE was a culotte. While we don't have any information about the stent technique used in the Excel. And we know from the DK crash free study that the culotte has a higher incidence of complication of MACE compared to DK crash. So concluding, although the results of Excel and NABL are conflicting, from the overall evidence of the literature, we can state that left main PCI is as safe and effective as the CFG, at least when the patient has a low complexity autonomy, as a patient with a syntax score less than 32. We can't avoid the fact that the PCI have a higher rate of TVR, but without consequences on hard endpoint. Thank you.
Okay. Thank you very much, Andrea, for this nice presentation. We are ready for the live cases in Russia, and so I would like to have on the podium Luca Favero and Sergei Volkov, please.
No, non ce li i casi loro non ce li abbiamo. Dico che i casi dei russi non ce li abbiamo. Sempre una.
Ah, questo è dopo, ancora dopo. Ah, questo è il pomeriggio. No, io lavoro con 40 minuti.
Hello.
Hello.
Dr. Merkelov, Dr. Tereshenko, this is, hello.
Hi.
This is Jacopo Reglia in Venice, so welcome to the TOBI again. And I just introduced the panel here is Mauro De Benedictis, Angela Migliorini, and Luca Favero from Italy, and we are now passing the line to you for your case presentation. Thank you.
Good morning, everybody. Nice to hear you. We have pretty interesting case for you today. That was a surprise even for us. And I'd like to start with the presentation.
Good morning, dear colleagues. I would like to present you our first case. So, 48-year-old female presented to our clinic with stable angina pectoris. The stress test results were positive with anterior and lateral wall ischemia. It is known that a year ago, patient developed anterior STEMI and underwent LAD and diagonal branch PCI with 2 bare metal stents. And coronary angiography showed that proximal stent in the LAD had restenosis. We saw new stenosis in the mid-LAD distally to the previously implanted stent, diagonal branch restenosis, and new stenosis in diagonal branch. In attempt to understand the mechanism of previous stenting, we started the previous angio. So here you can see the thrombotic LAD occlusion. Left circumflex artery and right coronary artery were without any significant stenosis. And the first step was the LAD stenting. Unfortunately, after proximal LAD stenting, diagonal branch was severely compromised. Therefore, operators decided to put additional 2.25 millimeter bare metal stent into the diagonal branch with the protrusion to the LAD. I would like to pay your attention that there were no final kissing balloon dilatation or any proximal optimization. So schematically, the previous stenting looked like this. So the first step was stent implantation in the proximal LAD, and the second step was stent implantation into the diagonal branch with a 5 millimeter protrusion into the LAD. So the blood flows to the distal part of the LAD through the stent cells without any final kissing balloon dilatation. And what we expect to see now is proximal LAD stent restenosis, new LAD stent stenosis distally to the previously implanted stent, diagonal branch stent restenosis, and diagonal branch new stent stenosis. Okay, thank you.
So, as you saw on schematically, we expected to see opened LAD and diagonal branches with some stenosis in it, restenosis. But what was surprise for us, I can show you the first image. We found that we have only circumflex artery opened, and LAD was occluded in the proximal part of the stent. Next. We inserted the wire. It went pretty easily through the stent lesions, as you can see on the screen. Next. We went to the diagonal artery first, pre-dilated the lesion. We found the diagonal artery pretty diseased. Then the second wire was inserted on the distal part of the septal branch. We managed to go only to the septal branch first, but then the third wire was used, and we inserted it to the distal part of the LAD. After some predilatation with 1.5, 2.0 and 3.0 balloon catheters, finally we achieved some flow in the diagonal artery and LAD. Minus. What we faced that the bifurcation is very diseased, and we can't open the 3.0 non-compliant balloon catheter. The last one? Minus. So that's what we achieved so far. Now we are going to perform IVUS into the LAD to understand what is going on in the bifurcation and to understand the true diameter and of LAD and the diagonal artery. If you have any suggestions how to deal with that lesion, I would be happy to hear you.
Coming back to the first procedure, do you know why bare metal stents were used? It was a matter of costs, or because it was an acute MI? Do you know why?
Yes, it was acute MI, and unfortunately, that situation is quite often in Russia. That during acute MI, bare metal stents are used.
Okay.
And here is the definitely consequences of bare metal stents. That's the
Whatever the treatment now, the situation is complex because if you plan to do stent again, I think that it's not so easy, not from a technical point of view, but from an outcome point of view, to do a restenting in this complex bifurcation.
So what is your suggestions? To leave it like that?
Uncommon.
That's the IVUS catheter we are going to use.
Great.
As you could see, it was not going easily, but now we are after the lesions. Can you see the IVUS pullback on your screens?
Yes, very well.
Good. We are close to the bifurcation.
So here's a hematoma in the plaque after dilatation. Some calcium, and here's a stent. It's 3.0, well deployed, and here the bifurcation starts. There's 2 layers of a stent on the 6 o'clock. And here a lot of tissue in the stent. Ага, выпал что ли?
Всё, выключай.
Давай.
Okay.
So the IVUS showed, a segment where there was a sort of neocarina between the two stents. This is important because I think that to plan a strategy to treat this bifurcation, you should really understand which is the mechanism. Of course, the mechanism of stenosis is mainly led by the fact that there were two bare metal stents in a bifurcation, which is a quite uncommon situation nowadays. And probably my strategy would be to use some balloons, some non-compliant balloon to optimize the bifurcation and then deliver some drugs with a drug-coating balloon if you have a good angio and IVUS result. But I don't know which is your strategy.
Have you got any difficulty to retrieve the IVUS? Would you comment?
Давай, Богу. Now we have the IVUS catheter stacked in the LAD.
Двушка где?
Параллельно куда?
Двушка.
Can we see the angio widened, the big image with the angio with the fluoros?
Here. I'm trying to pull it back, but it is stacked.
Можешь попробовать с проводником вместе потянуть немножко? Нет.
Что? We are going to use a new wire parallel to the first one in the LAD to inflate the lesion a little bit and to free this IVUS catheter.
Do you think that the problem is at the level of the neocarina, or in another side? What do you think? Where is the problem, in your opinion?
I think that the problem is in bifurcation. As you remember, the previous PCI was not ended with final kissing balloon inflation. We needed to go through the stent struts, and maybe the stent was not deployed completely.
What size was the balloon you used to dilate the LAD before performing the IVUS? Was it a 3.0?
We started with 1.5 and ended with 3.0.
Okay.
Держи.
Can we have on the wide screen the fluoro, please?
Можете переключить на флюро?
Anche diagonale, hanno dilatato anche diagonale?
Okay, thank you.
Come?
Hanno dilatato anche diagonale prima, solo
Sì, anche diagonale.
Both. Antecipati da sotto.
Может, дунем там, в середине?
Ну да. Нам надо баллон завести.
Давай баллон.
Держи.
There's a question from the audience. Which IVUS are you using, and if you have any particular preference?
It's Boston Scientific I love, and Atlantis, and the caster is Atlantis.
So now you try to go parallel with a new balloon
Yes. Он не входит.
at the level of bifurcation to inflate the balloon and disengage the IVUS probe, right?
Yes. But balloon catheter doesn't go inside the guiding catheter now.
What guiding are you using?
It's 6.
Is it a 6 or a 7 French?
It's 6 French transradial axis.
Жень,
There may be an issue to have a balloon and Boston IVUS in this 6 French catheter.
Пусти.
I think that if you cannot advance the balloon in this 6 French guiding catheter with the IVUS, you have to do a sort of ping-pong technique and put another guiding with a guide wire and the balloon to try to keep the IVUS out, to take the IVUS out.
Ногу давайте.
Ногу.
Yes, we are going to start with femoral access right now because we don't have an access from the right hand. The artery is occluded.
Is the patient stable? Chest pain, hypotension?
Yes, she is stable.
Просто еще раз попробовать дернуть, нет?
Сейчас. I'm going to try again.
Just pulling.
Нет, не надо, он растягивается.
No, it doesn't go.
And
The tip of the catheter is stretching, so it's not good idea to.
And have you advanced the probe more distal?
Yeah.
You know, there is a gap between the probe and the tip of the catheter. If you shorten that gap, probably you can make the system more stable and try to pull it out from the sledge, pushing the probe towards the end.
No, it doesn't.
We tried to engage the probe, but the tip of the catheter is stretched, so it doesn't go. The probe doesn't go.
Okay. Okay. There's a question from the audience.
Давай ногу, да.
Даша?
Needs more space because the guiding is 6 French. So he needs to remove now one of the wires that's already present in the bifurcation, and then he can go with the other wire and then do balloon. I think it will work.
Yeah, there's a comment saying that pulling out the wire in the diagonal, you may have the room to advance the balloon. But I think that in the 6 French guiding, it will be difficult. So in this case, you really need to have a second guiding catheter to do that kind of maneuver.
Давайте этот.
There's another question from the audience. And
Подлишь? Данияр, иди сюда. Данияр, иди сюда.
And it's not clear for me
Сюда, вот иди сюда.
which way
Сюда.
they have dilated both the ways. Which anatomical situation they had at the terms of the pre-dilatations.
Actually, from the IBUS, we saw sort of neocarina, but I don't actually know, because in the first procedure, as I understand, no kissing balloon was done. And of course, this is a problem, and probably they got through the stent struts, through the struts of the stent going from the LAD to the diagonal, and now it's a sort of a culotte, actually, but I'm not exactly sure about that.
Yeah.
And there was another question, which is from the audience, if a guideliner can be useful, and I think that a guideliner could be useful to pull it out, but you have to cut your IBUS, because you have to disconnect your IBUS, cut your IBUS catheter, put a 6 French guideliner on it, push your guideliner as far as you can in the coronary artery, like you do with, when a rota bar is stuck, and then try to pull everything out. But again, in this case, I would have a second access because of the risk of perforation, so you have to be ready with another guiding catheter. There's another question from the audience.
As I think before this option, I suggest to rewiring the diagonal branch and pull back the previous wire, because maybe one problem could be the struts, because the IBUS was just passed through the lesion and the stent. So maybe that the two wires are coiled together. So I suggest to rewire the diagonal branch and to pull back the previous wire and to try. Or another option, to pull back only the wire of the diagonal branch and try to retrieve the IBUS.
Okay. So what are you doing now?
We are going to try what you suggested with a guideliner, but we have Godzilla. We cut it, the IBUS catheter already. I will remove the wire from the diagonal artery scalpel.
Значит, только Годзилла может не пролезть на бифуркацию.
Of course, the IBUS is 5 French guiding catheter compatible, so you can use a 6 French guiding catheter extension, such like the Godzilla or the Guideliner or the Gideon, and you still have room for advancing it inside over your IBUS catheter inside the coronary artery. So in this situation, you really can have a deep intubation and try to pull it in a more coaxial way.
The problem is that the bifurcation was treated by 2 stents, and this prevents the extension to go deep further, because you already had a deep intubation with the guiding catheter. So I think that unfortunately, more or less, with a extension would be the same thing.
Yes.
Не клинься вот тут.
Come?
Можно 3,5, ну да, такой же.
Tagliato.
3,5? We have femoral access, and we are going to use the same guiding catheter with extra backups, 3.5, 6 French.
Okay.
Come? Ti capisci?
Vai in parallelo. So your strategy would be to try to pull it out with the guiding catheter extension. If it doesn't work, putting another wire on the distal LAD via the second guiding catheter, and then trying to advance the balloon and dilate in order to try to get the IVUS free.
Right, right. If we are not succeed with the guideline, with Guidezilla, then we will use the second wire to second guiding catheter, insert the wire parallel to the previous one.
Do you think that this can be also a problem with the fact that this kind of IVUS has a very short monorail segment, while, for example, the Volcano IVUS has a longer one, so like a balloon, actually, like 20 centimeters?
Ты снял Godzilla снял?
I don't think so. I don't think this is a problem. The problem is a real the carina. We have very atypical carina now with the stent. You don't know if the IVUS now is blocked in the diagonal stent, in the large stent, or in both. It's very difficult to understand which is where the problem, and it's not the IVUS, a kind of IVUS, I think so.
We couldn't advance the Guidezilla catheter inside the guiding catheter, so I guess we need to try to use the second guiding catheter and parallel wire, and then predilatation in the bifurcation to release the IVUS catheter.
So you're going to use a small balloon such as 1.5 millimeters.
Краник, дайте, пожалуйста.
Se mai vado avanti, un microcatetere, portare un microcatetere sulla guida per vedere se si blocca qualcosa.
Я держу,
But I think the IVUS has gone through now. Do you think a microcatheter through the wire could help to disengage or to enlarge some strut, a microcatheter through the carina?
Yes, but probably with a parallel wire.
It would be better, of course.
Yes. There's a question from the audience.
As far as I know, the probe goes in a channel in this IVUS catheter, and it's out now. Perhaps you could put a guide wire into this channel and make this shaft stiffer.
Okay. I don't know actually. So use the catheter such as like a micro catheter actually to advance, to retrieve your probe outside. Okay.
It is.
Okay.
Yeah.
Okay, I didn't know that. That would be a good point.
I think the tip of the IVUS catheter is broken or twisted, so that's the problem why it's not going out.
Ой, это же не контрастный кончик. Блин, да я тупой.
Новый проводник.
So I think that we are going to leave you work quietly because it's maybe a long job. So, but we leave you quiet, and then in the next session we will see how could you manage this kind of problem.
All right.
Okay?
All right. Thank you.
Okay. Thank you very much.
Thank you.
Thank you. See you later.
Thank you.
Так, Что-то, подожди.
Я в Вайвус.
Okay, thank you everybody, and I would like to invite
angiography that all you know, in terms of assessing of plaque distribution, extent, and real morphology, in terms of assessing vascular remodeling, plaque composition, central stenosis, reference vessel sizing, and post-PCI complication and results. What do guidelines say? Guidelines says that IBUS is class 2A with some bibliography in selected patients, but you can see the OCT in the same situation is in class 2B without any reference. This is because in the last 2 years, what the organizer asked me to show, this is the all evidence-based medicine about the imaging left main. 17 papers on IBUS, 7 papers on IBUS and OCT, just 5 papers on OCT. This is a very recent meta-analysis, 15 days ago, that compared IBUS and angiography and showed that IBUS-guided PCI in terms of all-cause death and cardiac death is better than angiography. All you know is very important. It's a milestone paper by Justin that show us that the IBUS determinants in patients with a SSFAR less than 75.75 is 2.8 millimeter MLD and 5.9 millimeter square of MLA. Basically, of this paper, the MSS threshold values for the prediction were established 9 millimeter square for left main proximal, the polygon of confluence 8 millimeter, and the ostium of circumflex 6, the ostium of LAD 7. This is the Excel trial. It was a trial on PCI versus cabbage in left main. This trial shows that 73% of patients were treated with PCI IBUS guidance, and they show a very interesting question. Pre-stenting only was 16.4, post-stenting only 39, and pre- and post-stenting only 43% of patients. And in the same paper, in the same study, they show that the rate of change by IBUS was 50%. In 50% of cases, the operators changed their strategy according with IBUS in terms of use a larger balloon, post-dilatation, used higher pressure, treat the stent under expansion, led to provisional one-stent strategy rather than planned 2 stents, and finally led to planned 2 stents strategy rather than provisional 1 stent. This is the experience by Florence, by Angela Migliorini and David Antoniucci and all his their group. 760 patients from 204 to 016. The patient had a median Euroscore 6.1. Half of patients have an Euroscore more than 6. The large majority of patients have a Sinta score more than 32. Very interestingly, in the stenting of both branches, were no difference in case of syntax more or less 33. The IBUS guidance was more used in patients with CETA score less than 33 than in CETA score more 33. This is our experience with Dr. Colombo in patients with rotablator in left main, and we show that the unprotected left main uses more rotablator than unprotected left main, and you can see that in 3 stent thrombosis, in 2 cases of stent thrombosis, the IBUS was not used. Again, another Italian study, very interesting, from Tascenso, that showed that insulin diabetes mellitus increased the risk of TLR on unprotected left main, but the use of IBUS resulted very protective in these patients. This is a very big registry from Sweden, 2,000 468 patients where IVUS guidance were used in only 25% of patients. They showed that the comparison between patients with IVUS and non-IVUS, it was in favor of patients that were PCI was done with IVUS. The mortality too, but not the restenosis. But what is very interesting in this case is in all subsets of patients, the IVUS was better. And this is, again, more and more interesting. The beneficial effect of increasing stent diameter was nominally more pronounced in the IVUS group. You can see the IVUS group, per 1 millimeter increase, it was an increase in outcome. This is the first study that was in indirect comparison between OCT and IVUS. Really, it was not focused on the left main, but the bifurcation lesion was 45.7% and 46.9%. This study compared two different studies, Illumin-1 and ADAPT-DES studies. In Illumin-1, they use OCT. In ADAPT-DES study, they use IVUS. As you can see, they showed that there was no difference in terms of stent expansion. But in this other study that compared directly IVUS and OCT, the Illumin-3, whereas the 37% of patients were on bifurcation, they showed that minimum stent area, it was no difference between OCT, IVUS, and angiography. This is the first study that compared the three different imaging possibilities. But in terms of minimum stent expansion, you can see that it was only a difference between OCT and angiography, but not a difference between OCT and IVUS, and the same thing for mean stent expansion. Whereas in the OCT, at the final procedure, it was less dissection and less malapposition, major malapposition. This was the third study that was a comparison, a direct comparison between OCT and IVUS, the opinion trial that showed a non-inferiority test for TVF and TVF free survival curves through 12 months of follow-up. And finally, two very interesting and intriguing papers from Policlinico Gemelli of Rome, from Francesco Buzzotto, that show that OCT in left main coronary artery. What they show that the percent of heart fat frames was much more in proximal left main, and then is decreased with an optimal correlation between QCA and OCT. And they suggest some tips and tricks to perform OCT in left main. The coaxial coronary intubation, an appropriate contrast medium flow during scanning, because we know the left main has a major size respect the other vessel, and prefer OCT, maybe mid and distal part of left main at bifurcation. And the second study showed that OCT showed a major plaque distribution than angio just in these two kinds of Medina, Medina 111 and Medina 110. Finally, some take-home message. Angiography can overestimate left main severity in terms of cranial projection, and angiography can underestimate left main severity, especially in setting of diffuse disease and no clear reference segment. Secondarily, IVUS, and it showed that an MLA more than 6 millimeter correlates with good outcomes, and if guide wire is not coaxial, MLA may be over or underestimated, so consider IVUS into both LAD and circumflex. Thus, also in IVUS, we must use some tips and tricks to be sure of the result. About the OCT, less used than IVUS and FFR. Flushing may be inadequate in the ostial and proximal left main. Larger diameter left main lesions may also not be fully visualized. Two contrast flushing protocols required to assess LAD and left circumflex. This is a suggestion from the experts. In expert hands, it could provide a better assessment of apposition, plaque protrusion, and plaque distribution. Anyway, we know that any imaging is largely underutilized in left main tract treatment, maybe because after a challenge procedure, we don't need nothing more. Thank you for your attention, and I would like to thank and to say hello to David Antonucci. Everywhere I stay, grazie Davide per tutto quello che mi hai dato.
Thank you very much, Rino, for your presentation and your words. And now we are moving back to Moscow. We will have a turnover of the discussion, so I thank Francesco and Andrea, and I am inviting to the podium Carlo Cernetti, Giampaolo Pasquetto, and Prokhor Pavlov.
Давай. 18. 20.
Hello, Moscow. We can see you. Can you hear us?
Yes, we can hear you. Закончили. We still have the same.
Jacopo Reglia. And in the discussion we have Carlo Cernetti, Giampaolo Pasquetto, Angela Migliorini, and Mauro De Benedicti. So we are waiting for your images. Tell us what we have done.
Так, давай с последнего. We have the same patient on the table. Unfortunately, we couldn't withdraw the IVUS catheter. We tried to use the wire inside the IVUS catheter, but it wasn't go through the catheter. It stuck like here, right near the tip of the IVUS catheter. So we used the femoral access to introduce parallel wire. We managed to do it, but I think that we used the different strut, not the same strut that was used for IVUS catheter. Balloon dilatation in the bifurcation didn't give us anything. Finally, we used Godzilla catheter very close to the bifurcation and tried to withdraw it very hard, but finally we ended up with broken IVUS catheter. We compared broken part with a new one and understood that it was very short tip that was inside the LAD, not going into the aorta. To check it, to control it, to be sure that we were not in aorta, we performed one more IVUS, which showed us that the previous IVUS catheter was broken right in the bifurcation site. We can show you IVUS finding right now.
On IVUS, we can see the catheter.
Okay, great.
Right here. So it's a tube, and it goes. There's a metal here. It's a steel tube, and it goes to the bifurcation till the stand. So here it is, and on the bifurcation it ends.
Nitro. So then, after understanding that we have the broken part inside the LAD, going from bifurcation to the middle part of the LAD, we decided we decided to stand the broken part with a very long 48 millimeter synergy. You can see it goes very well up to the distal part, covering the broken part of IVUS catheter. Here is the deployment. Then we checked that we need to cover the proximal part with 38 millimeters, and we used another synergy stent, 38 millimeters, up from the ostium of the LAD, with some overlapping in the 48 millimeter synergy. Here's the deployment. Minus. We checked that we didn't cover the ostium of the circumflex artery. Plus. You can see that that the balloon catheter fully expanded even in the bifurcation site. Then we checked with IVUS again, and understood that we need some post-dilatation with non-compliant balloons. We used 2.5, 20 balloons and 3.0, 20 for the proximal part. And now I'm going to show you the image what we achieved. Blood flow is something like TIMI2, but the artery is opened, and we have still a live diagonal artery.
Okay,
what do you
very
think?
Good management of. I think that, I mean, you were lucky that the catheter was broken inside the artery, and then you did the right thing because since you could not retrieve the IVUS catheter, you did the right thing. You deployed a stent, and this is a safe result to me. And I'm just wondering what is your strategy on that diagonal branch, which is nice, but it's which is long, but is with a TIMI2 flow and with a tight stenosis at the ostium, and then you have a lot of metal over there because you have the previous stent, the newer one, and the diagonal stent.
I guess because of the diagonal artery is so big and alive, we need at least to try to wire it. If we are lucky, we will try to stent it. If we are not, then we will leave it like that. Because I understand that there are many layers of stents in that bifurcation, and introducing the wire might be difficult.
Hi, can you hear me? Yeah. You think to place another stent in a diagonal branch will be a good idea? I will just try to cross and to maybe perform just a kissing final balloon. What do you think about, or maybe if you really want to place or to use a drug-eluting balloon, maybe on the side branch, and a standard non-compliant balloon on LAD?
That's a very good idea, actually. If we are lucky to insert the wire inside, first we will perform kissing balloon inflation, then we'll see what is going on with the diagonal artery. Maybe we will end it up with drug-eluting balloon, and that's it.
Okay. Which wire are you using to try to cross the diagonal branch?
That's PT2 from Boston Scientific. It's our workhorse wire. I know that's hydrophilic. And, but we used to work with them.
There's an interesting question from the audience that says, are you considering indefinite dual antiplatelet therapy?
I guess we need to control this patient in a year with OCT, and to be on the safe side and understand that everything is covered, and then to stop or continue antiplatelet therapy.
Yeah, looks you were able to pass through the struts quite easily. Or what's your feeling?
Yes, I am trying to reach the biggest branch.
Okay. maybe it could be an option then to try to exchange the wire you are using with one with a higher, let me say, support like BHW or BMW in order to be sure to cross then with a non-compliant or a semi-compliant balloon the side branch.
Minus. I guess we are in.
That's a huge diagonal branch.
Yeah, it's very big. Yeah. So it really deserves some treatment. And but I agree. I think that probably putting another stent will be too much metal in that artery, in that bifurcation.
Or maybe a drug-eluting
balloon could be a good option.
We will try to perform.
Who in the audience would go for another stent in the diagonal? Nobody. Okay.
Another side effect, of course, of placing all these stents is that, as you can see, all the collateral are, unfortunately, most of them have been included.
The septal stent.
Yeah. So I think
that, that is a bare metal stent, so it may stay open even with balloon dilatation and probably drug-eluting on the stent, because even it's really a very particular lesion in this case, but we have good results of drug-eluting balloons inside bare metal stent stenosis. So.
Even because, as we have been showing, the place that the IVUS was stuck before the bifurcation, so actually it could be easy that with a drug-eluting balloon it will be enough to maintain open at the diagonal branch.
But if you think about long-term outcome, I don't think that this 2.25 bare metal stent treated just with a balloon or drug-eluting balloon would be good. I think that although restenting is not a good option in terms of technical issues, but maybe I think that it will be the only chance to have an acceptable long-term outcome. The stent was at least 23-24 millimeter long, 2.25 diameter, and I think this is a diffuse restenosis that involves more than 25-30 millimeters. So I don't think that just with a
drug-eluting balloon.
The balloon passed quite easily.
But not distally to the stent. I can't introduce it furthermore.
Может раздуть, он просто цепляет.
Раздуй.
The side lesion.
I think if you open well,
it slided.
Okay.
Slide it down.
No, it's gone.
Yeah. Because there is a restenosis there.
10 atmospheres. Need to control the tip of the guiding catheter. I don't want to destroy the stent. It goes easily into the stent.
Yeah. Good point. I think this is a teaching point for the audience. When you have a stent placed on the left main and you are working on a proximal bifurcation, you have really to take care of that, because the risk is really to destroy the first struts, and then you have again to think how to repair that. This is a normal semi-compliant balloon, what you have in the diagonal?
In the diagonal, yes, it's 2O semi-compliant balloon.
Okay.
Давай.
It's a 2520.
Больше. 10.
Не комплайнт, 2,5 давайте.
18.
I'm thinking at this point who will use, now that the struts are well opened, maybe a cutting balloon to,
Maybe an option.
before using a drug-eluting, or before maybe you take the chance to place another DES. But I think cutting balloon to prepare the lesion and to be sure, because unfortunately with just a semi-compliant balloon, I don't think you obtain the chance to then being able to place down something with a higher profile.
Смотрите кого-нибудь.
14. Закончим. Сейчас одновременно.
Coming back to the question of antiplatelet therapy, I think that this is a good candidate to very, very long antiplatelet therapy, because the previous MI, and then the length of the stent is, I think,
quite long.
So, if based on hemorrhagic risk, of course, I think that
totally agree.
Indefinite.
I don't think we have an instrument today to say, okay, with OCT you can, of course, evaluate the percentage of coverage of the stents and localization, but I don't think we will stop.
Colleague spoke about OCT control, but I think
I don't know if this is enough.
For sure, with a double.
I think this is really a perfect candidate for indefinite. Vediamo. Sta mettendo.
16, 18.
Ok, fa una specie di bot. Are you considering or are you performing a kind of bot to open?
Yes, I'd like to optimize a little bit proximal part of the stent, where the two balloons was touching each other.
Okay. This is a non-compliant balloon?
Yes, this one is non-compliant. 3012.
40 or?
It's 3012.
30. The IVUS, the diameter of the left main, was it bigger or?
Proximal part of the LED is 3.2, 3.6.
Okay.
Oh, 3.2.
It's better, but still the blood flow is slow. Ostium of the diagonal artery is diseased, stenotic, and we have disease distally to the stent in the diagonal artery.
Yeah, I think maybe some adenosine to see better the flow. I think it will improve if you have the chance to use some adenosine. I think the flow will improve, because now we have a lot of embolization, of course, distal, and then I think blood flow can improve easily with some adenosine. What do you think about?
Yes, maybe. I don't think that, I'm not sure that we need to cover the diagonal artery with another stent, but at least we can perform kissing balloon inflation with drug-eluting balloon. What do you think? 2.520.
I think think it's a good idea. Personally, I will perform with a non-compliant balloon in the diagonal branch, high pressure, like 25, 26 atmosphere, in order to open really in a good way the diagonal branch. And then I will perform the dilatation with a drug-eluting balloon, and then finally kissing balloon.
But what about what about this disease distally to the LAD, distally to the stent in the diagonal artery? Do you think we need to cover it with a short stent, for example?
No, I wouldn't touch.
Это у нас трешка. So we have 2.520 non-compliant balloon catheter for the diagonal artery to open the struts more.
Perfect.
And the same 3.012 inside the LAD.
Perfect. I'm even using a lot of scoring balloon in this kind of cases, like acrostagrip, or there are many on the market. Especially in case of restenosis, they are really working fine because they are well fixing the lesion and they are not slippering inside of the restenosis. But I think now that the lesion is already well prepared with a non-compliant balloon on a diagonal branch, I think it will work fine.
Is there some dissection distal to the stent on the diagonal branch or not, or is just a disease?
It's I guess it's dissection because if you remember the previous angiography from the last PCI, there was a plaque, there was a stenosis distally to the implanted stent in diagonal artery, and after dilatation, I guess this is consequence of dilatation in the diagonal artery.
So it's not so easy to take the right decision in this case, because if you leave a dissection distal to a restenosed stent, the rate or reocclusion is not so neglectable. So the feeling is that if you want to close the procedure without any problem, you have to restent with a long stent, also the diagonal. I know that it's not ideal, but maybe you can.
It's 4 atmosphere in the diagonal artery. Look, the balloon is not fully expanded in the stenosis.
Сейчас не презентацию включится.
Давай еще. 6. 6. Don't want to be aggressive on that plug.
There's a question about, actually 2 questions. One is about GPI inhibitors. Are you using GPI inhibitors in this case, or are you planning to use them or not?
No, we are not using them right now. ACT is normal, we control it. I guess right now there is no need to use them.
Great. Okay, and another question is about the situation of the patient if she's feeling some chest pain or some other symptoms.
No, she's fine, she's stable. What do you think? It's fully expanded, I guess, in the bifurcation.
Yeah. Looks like. Really. If you want to be really sure, I think you should make a LAO projection, because there I think you're able to see if the non-compliant balloon is well expanded on the diagonal. You have an orthogonal projection that is ensuring you of this.
Смотри, внизу есть картинка исходная. Можем напомнить.
14, 16, 18. 20 atmosphere on that 3012 balloon. По 10.
At this point, I think it would be really useful to use some adenosine before you take the last picture.
Давай. Двадцать. Закончили.
Okay.
Держите два.
Сейчас 4 минуты.
Держи эту.
Coming back to the question of stenting the diagonal branch, you will of course place a long one that is starting down where the disease was up to the proximal LAD and then opening the struts through the LAD. What do you think? Or what would be your preferred strategy?
Well, in this case, I think that tap technique with a long stent, if you plan to put a stent, you need a long stent with a tap technique. I don't want to have more struts in the LAD. Right.
Okay.
So to cover the previous one and also the dissection digitally.
Yeah.
And then final kissing LAD diagonal.
Yeah.
To not confirm balloon.
There's a question about the new strategy to adding rivaroxaban.
This is really a good
based on the recent presentation to the ESC. I think that.
So what do you think? Do we need to stent the diagonal artery or use drug-eluting balloon? It looks better.
I would go for a drug-eluting balloon, actually.
Yeah. Yeah. From the audience, they do suggest to perform a drug-eluting balloon, and then maybe, I'm sure you're going to take a coronary angio in 3 or 6 months, and maybe you take the chance to treat the diagonal branch distal in case just you have really severe residual stenosis over there. Because I think maybe he's going to repair this dissection.
Drug-eluting balloon, correct. I hope to show you the follow-up in a year, personally in Venice.
Okay. Good option.
Не тот.
It is already the drug-eluting balloon?
No, that was wrong wire.
Okay. Have you got any reference for the drug-eluting balloon, in the meaning that you are using just a paclitaxel eluting balloon, or now we have even on the market a sirolimus eluting balloon that is named Evois?
We have only paclitaxel covered available.
Okay. But I think it makes sense. Not now with the bare metal, but I think when you have a restenosis with an olimus stent, it has a sense to treat it with a paclitaxel drug-eluting balloon than with another sirolimus-derived drug. What do you think?
Yes, I think that we would go for paclitaxel. Maybe we have also much more evidence on that kind of drug compared to sirolimus.
My choice was in favor as a choice of drug-eluting balloon in this case, but I have some concern, like told Mauro, about the dissection also
distal to the
stent. So
the question is that at this point you have one. At this point you have 1, 2, 3 struts.
Yeah.
And now you put the fourth.
So we have 3O12 in the
but
LAD.
The flow now is a little bit better,
and
the diagonal branch is very large.
Yeah.
So maybe after all this hard work, maybe you can try to optimize. No way. So if you have to put a stent, you can do it.
So, Evgeny, unfortunately, the time is almost over, so we will probably not see the final results, but your strategy is that of the drug-eluting balloon. So if you confirm that and your final strategy, we will then say bye-bye to you and wait for the follow-up next year.
Yeah, this is drug-eluting balloon already inflated. So I'd like to thank you for your attention and for your advice. It was very nice to work with you.
Thank you very much. Thank you. Thank you. Bye-bye.
Bye.
Okay.